Welcome back to Decode Healthcare with Harshal. Listen, today is a massive milestone because we are officially stepping into Chapter 4 of the ICD-10-CM, Endocrine, Nutritional, and Metabolic Diseases. In this explainer, we're taking on our primary mission, Section 1C4A. We are going to conquer the absolute heavyweight champion of medical coding exams and clinical audits, and that is diabetes mellitus. If you've been coding for more than, say, 24 hours, you know that diabetes coding isn't just common, it is intensely scrutinized. It's a big deal, so get ready because we're going to master it today. Okay, let's dive right into our structured roadmap for this explainer. First up, conquering diabetes coding. Then, the 5 core categories. Third, the ultimate default rule. Fourth, stacking combination codes. And finally, number 5, avoiding drug code traps. We're going to decipher those tricky clinical clues and apply strict CMS laws to arrive at the absolutely perfect compliant code combination. All right, part 1, conquering diabetes coding and the hierarchy of sources. Now, as coding detectives, our very first rule of absolutes is that the CMS ICD-10-CM official guidelines strictly override any other textbook. Period. Textbooks, they're fantastic for your foundational learning, sure, but when it comes to an actual clinical audit or sitting for your certification exam, the CMS guidelines are the ultimate law of the land. That's exactly why we are pulling our clues straight from Section IC4A today. We're going right to the source to make sure your claims are completely bulletproof. Now, check out this brilliant quote straight from the CMS guidelines. It proves that diabetes coding isn't just, assigning a single random number to say a patient has high blood sugar. No way. It is a comprehensive mapping of systemic damage. When you code diabetes, you are essentially telling a highly detailed, very specific story about exactly what this disease is doing to the patient's entire body. Moving right along to part 2, the 5 core categories and building that map. Let's look at our foundation and see how it builds the diagnostic map we need to navigate Chapter 4 effectively. So the ICD-10-CM categorizes diabetes into these 5 distinct code families. It's not just one big bucket. E08 is for diabetes caused by an underlying condition, like cystic fibrosis, for example. E09 handles diabetes induced by a drug or chemical. Think prolonged steroid use. E10 is reserved strictly for type 1 diabetes, where the body basically produces little to no insulin. Then we have E11, which is type 2 diabetes, definitely the most common form, where the body is insulin resistant. And finally, E13 captures other specified types, like post-pancreatectomy diabetes. Knowing exactly which family you're starting in, that is absolutely crucial. It's step 1 for a clean claim. Okay, part 3, the ultimate default rule and solving the vague clue. So what happens when a provider leaves us with a terribly vague clue in the medical documentation? We've all been there, right? You're reading the chart, and the doctor just writes, patient has diabetes. That's it. No type, no details, just diabetes. It can literally stop a new coder right in their tracks. But listen, you do not guess, and you definitely do not panic when you face this super common high anxiety scenario. You don't even need to send an immediate query to the physician because the guidelines have given you a built-in safety net. The official guidelines command you to default directly to category E11, type 2 diabetes mellitus. It ensures absolute compliance without you having to make any dangerous clinical assumptions. Because type 2 is overwhelmingly the most common form of the disease, the classification just presumes it unless told otherwise. So if the chart just says diabetes, you confidently shine a spotlight on E11 and just keep moving forward. Let's hit part 4, stacking combination codes and building the claim. Now, what's really interesting here is how ICD-10-CM elegantly handles the domino effect of diabetic complications. It's all about integration. Instead of listing problems separately, like putting the diabetes code here and the kidney disease code way over there, a combination code embeds both the diabetes and its associated body system manifestation into one neat alphanumeric package. It's like a 2-for-1 deal. The code essentially says to the auditor, hey, this patient has diabetes, and the diabetes is the direct cause of this specific complication. And here is the kicker. If a patient has, say, 3 distinct diabetic complications, like retinopathy in the eyes, nephropathy in the kidneys, and neuropathy in the feet, you must literally stack 3 distinct combination codes to fully capture that clinical picture. You assign as many codes from that diabetes category as needed. You absolutely do not just stop at 1. Here's a perfect example of this in action, E11.22. This brilliantly illustrates how a single code seamlessly communicates both the type 2 diabetes and the nephropathy complication directly to the payer. It's so efficient. But as a quick side note, remember that the guidelines also states that for chronic kidney disease, you'll still need an additional code from the N18 category to specify the exact stage of the CKD. When you stack these codes correctly, you're painting an absolute masterpiece of clinical accuracy. Which brings us to our final phase, Part 5, Avoiding Drug Code Traps and the Z79 series. Welcome to the high-stakes world of long-term drug tracking. This is where seasoned coders can easily get caught in dreaded audit traps. So this matrix right here breaks down the strict Z79 secondary codes you are absolutely required to append to track a patient's long-term medication regimen. Z79.4 tracks long-term insulin use. Z79.84 tracks oral hypoglycemics, like metformin. And Z79.85 tracks the long-term use of injectable, non-insulin anti-diabetic drugs. These codes are vital because they tell the insurance payer exactly how intense the patient's daily management has become. But the crucial point is right here. And honestly, this is where auditors make their money. Assigning Z79.4 for a type 2 diabetic, perfectly compliant and totally necessary because insulin use isn't inherent to type 2. But if you code Z79.4 for a type 1 diabetic, that is a major audit error. Why? Well, because a type 1 diabetic, by definition, produces no insulin. They absolutely require it to survive. That insulin dependence is already baked right into the E10 code family. Adding Z79.4 to an E10 code is completely redundant, and it's going to trigger an instant red X on any code validation screen. Don't do it. Oh, and one more thing. Actually, scratch that. This is incredibly important. You must never fall into the trap of assigning a long-term drug code if insulin is only given temporarily. If it's just a sliding scale insulin drip used for a few days to bring blood sugar under control during a brief hospital stay, no way. The keyword in the Z79 category is long-term. Temporary does not equal long-term, for sure. Whew, okay. We have covered a massive amount of ground today, from category mapping to complication stacking to dodging those sneaky Z79 audit traps. But I have to ask you, what happens when our diabetic patient becomes pregnant? Well, be sure to like this explainer and share it with your study groups, because in Part 39, we are going to reveal how Chapter 15 literally throws all of these rules out the window and presents a brand new, highly complex coding mystery. Keep decoding, keep learning, and I'll see you in the next explainer.